I am going to speak tonight about pregnancy and gestational Lyme. And first of all, I want to share that Maggie from the US, she actually came here. Maggie used to be one of Dr. Jones's nurses, and she was the one who got me very much interested in pregnancy and gestational Lyme. So Maggie, thank you for making the trek all the way across the border to come and be here tonight and to support me as I share this presentation. I don't have any conflicts of interest. I'm a registered nurse. I graduated summa cum laude from McMaster University in 2001. And I just want to say something about that. My training, it was absolutely incredible and important because what they taught us in nursing school was something called problem-based learning. So if you have a problem, you got to figure it out, even if the problem is outside the box of what is usually normal. And so this is something that has put me in good stead now as I continue on with Lyme disease. And I'm a co-founder, as you know, of LymeHope. Okay, so what is vertical transmission? This is when an infection that is caused by an active pathogen, such as a bacteria or virus, is transmitted directly from mommy to her embryo, fetus, or baby during pregnancy or childbirth. The term congenital infection can be used if that infection persists in the baby after childbirth, causing chronic postnatal infection. Now, evidence of infection might be seen in the baby right at birth, soon afterwards, or not until years later. And this latency, or this kind of a pause in symptoms coming out, has been noted in both HIV and syphilis. So this is not new. This is well known in some of the other infections that are transplacentally transmitted. So there's some other species of Borrelia that we know can create adverse outcomes in pregnancy. Borrelia dutoni, which is well known as relapsing fever throughout sub-Saharan Africa. Borrelia hermsii, which is known as tick-borne relapsing fever. And of course, syphilis. Now, syphilis is not Borrelia, but it is a spirochete. And indeed, it is taxonomically related to syphilis. They are both spirochetes. We all know about syphilis, don't we? We know that women are screened prenatally, doctors are on the lookout for syphilis for that reason. So what about Borrelia burgdorferi, which is Lyme disease? Can it be transmitted in the womb, causing congenital disease? Well, the simple answer is yes, it can. This next slide is actually very important. This is from 2016, from the Infectious Diseases of the Fetus and Newborn Infant. This is a medical reference textbook which your physicians in training would be using. And they have a suggested acronym, an updated acronym for microorganisms responsible for infection of the fetus. For those of you who are medical professionals, you're probably used to the term TORCH. So they've added TORCH's CLAP. And you can see that the L here stands for Lyme disease. So they've added Lyme in as being one of the microorganisms that can be passed from mother to child. Okay, a little bit more about my story. So in January 2016, I was diagnosed here in Canada with late-stage chronic disseminated Lyme disease. Now, I also tested positive, 2-tier positive within our system, which is quite rare. Okay, and initially I was told it was a false positive, but I persisted and that diagnosis was soon overturned. And anyway, I had been sick with over 15 years of progressive symptoms, including tachycardia, memory problems, choking, coughing, migratory pain, peripheral neuropathy, and profound fatigue. So soon after I'd been diagnosed with Lyme, I connected with another amazing woman, Joanna. Joanna is a researcher, and she has Lyme disease and has been very, very sick. And Joanna and I went over to her house, and we would sit around, and I would say, Joanna, there's something about this disease. I don't know enough about it. And she said, don't worry, Sue. I'm going to help you. And so she started accessing literature and helping me get the primary literature specifically related to maternal-child transmission. I didn't know it at the time, but that's what she would help me with. So thank you so much, Joanna. Can we just clap for Joanna? She's an amazing, amazing woman. And I truly I truly believe that if this disease does get acknowledged, and it will get acknowledged in Canada as being transplacentally transmitted, Joanna's going to have a major part in that actually happening. So it's pretty impressive. So anyway, here we are. This was one of the first articles she sent me, and I was rather shocked when I read it. And here you see, it's from Health and Welfare Canada, 1988. And it says right there, transplacental transmission of B. Burgdorferi has been documented and may be associated with an increased risk of adverse pregnancy outcomes. So I was like, my goodness, I never heard of this. I had been diagnosed with chronic disseminated late-stage Lyme disease. Nobody ever told me that this could be passed from mother to child. And in fact, it wasn't long after that I started doing more research, and I came across this paper by Dr. Charles Ray Jones, who's our children's pediatrician, and Maggie was his nurse. And as I read this paper, I'll be honest with you, my heart sank. Dr. Jones described in his paper that a majority of mothers were diagnosed first, and then their children were diagnosed retrospectively. He talks about diagnosis having to be clinical because the serology is not accurate and will not pick up all cases. And something that really was compelling to me was 66% of mothers who had congenitally infected babies had a difficult pregnancy. And I had horrible pregnancies, every single one of my children. So that, to me, was a huge red flag. He goes on to talk about the multi-system symptomology in children who are born with Lyme disease. And if you look at this list, it is rather overwhelming. I read this list, and I started to cry. Because indeed, all three of my children from birth had suffered with multi-progressive symptoms. Now, they didn't all have these symptoms, but they certainly had many of these symptoms on this list. And right then and there, I knew that I had passed this infection to my children. And so we ended up getting our kids tested in the US, and unfortunately, the Western blots came back positive, showing evidence of exposure to Lyme disease. And also, unfortunately, I went to physicians here to share my concerns, and I was told they wouldn't even talk about it. They did not want to talk about it. And I felt sick. So we brought our children to see Dr. Charles Ray Jones. This was our first visit. This was when Maggie was still there. And there you can see what an incredible man he is. And he speaks to how complicated a diagnosis gestational Lyme is because of delay of presentation, the multisystemic nature, and the transient nature of symptoms, and the unreliability, this is very important, the unreliability of standard diagnostic tests. Okay, this is a rather disturbing letter. You might not actually be able to read it, and that's okay. But I put it up there because after I went through all this with my children, I actually did get my children tested in Canada as well, because I figured, knowing the testing kind of ratio, that it's kind of like a flip of a coin, whether or not you test positive or not, I figured one of my 3 kids would test positive in Canada, and I was right. So myself, I was a 2-tier positive, and one of my daughters was a 2-tier positive, and I was ecstatic. Can you believe it? A mother's ecstatic about a positive serology in Canada. And I called up public health, and I said, guess what? I think I have a case of vertically transmitted transplacental Lyme. We could be a family that you could study. This is amazing. I said, can I come in and talk to you? I have all this literature, I have all this stuff. And anyway, the response I got back was this letter. Regarding your concerns on congenital transmission, our health department has conducted a lit review. And as a result, there's no scientific evidence to support congenital Lyme disease in the scientific literature that was found. That was it. And they attached the lit review. So I was like, okay. So I took a look through this lit review, and I'm seeing authors like McDonald and Schlesinger and Weber, and I'm like, are you kidding me? Did you read the lit review? So I call up the public health. I said, did you read the articles that you sent me? Because these are the seminal articles. These are the ones that prove that the transplacental transmission is possible. And the response I got back was, no, you can follow up with your family doctor. And so for those of us who are moms in the room, when something gets you mad, you do something about it. And that was when my advocacy started to go into full force. So let's take a look at the research on maternal transmission. 1988, Alan Steer and Dr. Duray. Some of you will know that Alan Steer was one of the first researchers to go into Lyme, Connecticut, and discovered Lyme for what it was. So they co-author a paper, and included in this paper is this paragraph: "It is clear that Borrelia can be transmitted, Borrelia burgdorferi can be transmitted in the blood of an infected pregnant woman across the placenta and into the fetus. Transmission resulted in congenital infections and fetal demise. Heart abnormalities have been seen. Spirochetes have been recovered from infant tissues, including brain, spleen, and kidney." So this, of course, piqued my interest, and I called up Joanna. I said, "Hey, I need you to start pulling up articles for me." So here we have Schlesinger and McDonald. Case report, 2 case reports here. Briefly gonna review them. So both these women were bitten by a tick in the first trimester of pregnancy. They both had an EM rash, but they were not treated. The first infant was born at 35 weeks and unfortunately died after 39 hours. Autopsy of this baby showed widespread cardiac abnormalities, and spirochetes, Lyme disease spirochetes, were found in the spleen, kidney, and bone marrow. Dr. Alan McDonald later demonstrated Borrelia in the myocardium of this infant as well. Case report number 2, we have Dr. McDonald. He's a pathologist, and it's another story of an untreated mom. Interestingly enough, in this study, they actually sent her serology to 3 different laboratories. 2 of them come back positive, 1 of them comes back negative. So we're already seeing that this serology, this blood testing in Canada, not in Canada, in the States, is not as accurate as it should be. Spirochetes, again, are cultured from the liver, heart, adrenal gland. They're cultured from the liver, and they're identified in the heart, adrenal gland, placenta, and midbrain. And Dr. McDonald states overwhelming spiroketosis. So these spirochetes are everywhere throughout this little baby's body. So here you can see a picture of a spirochete in fetal heart tissue and also in fetal kidney. So they conclude pregnant women who acquire Lyme disease must be treated promptly with antibiotics. If a mom has been exposed to Lyme in pregnancy, the placenta should be examined for histologic abnormalities as well as spirochetes. That spirochetes may spread transplacentally. If an infant is ill, a differential diagnosis of congenital Lyme must be considered. And then McDonald also states that a clinical diagnosis is absolutely critical because the gold standard testing will not always be helpful. So here we have 2 cases of transplacental transmission and an association with fetal death and cardiac malformation. Next, we have a study done by the CDC. They take a look at 19 women who were infected during pregnancy, and out of those 19 women, 5 have adverse outcomes, pretty significant adverse outcomes. And they decide, and there's consensus, that this is a high frequency of adverse outcomes, but because it is such a heterogeneous range of adverse outcomes, they feel that it's not enough to make a kind of a causal association. And so they say there's no proof that Lyme disease was responsible for these outcomes. Case report number 3. This is, one of the authors is from Yale University here. This mom was from California, which was a low endemic area. She doesn't remember getting bitten. She just had all kinds of weird symptoms. And she didn't get antibiotic therapy. There was neonatal distress. The baby was born by section. And here's something interesting. Baby's initially healthy and discharged home. And at 8 days is readmitted back with multi-system progressive multi-system failure, and he dies. Upon autopsy, Borrelia is cultured from his brain. Both mom and baby are seronegative. Okay, so it's something very important. They do not pass serology, okay? Case number 4, so this is from Germany, 37-year-old mom. She's bitten in her first trimester. Now, she's treated with a week of penicillin, a week. However, she also delivers a healthy baby, and within 23 hours, the baby develops respiratory distress and dies. Borrelia burgdorferi is found in the brain and liver of the deceased neonate. And there's another interesting point that they make is that there's no inflammation found in the organs of these babies, these congenital babies. And they ask that question, why? Why is there no inflammation? Doesn't make sense. And this will be answered in a few minutes. Dr. McDonald is at it again. This time he presents 14 cases of fetal and neonatal outcomes. And here he has a little chart, very interesting. If you look at that chart, you can see that maternal serology is often negative, and yet tissues found in fetal, upon autopsy, the spirochetes are found. So again, saying the serology is not linked to finding these organisms in these children. He also talks about, again, about tissue inflammation and that it's absent, and it's a question as to why. Here's some pictures. This is a baby who this baby was born and 4 months later passed away unexpectedly from SIDS, and Borrelia burgdorferi was found in the infant brain. How many SIDS babies are we missing that potentially could have Borrelia burgdorferi? I'm not going to go into serosurveys, but serosurveys is basically a test where a survey where you test a cohort of pregnant women, and then you see what percentage of them are seropositive, and then you follow them through their pregnancies. So these serosurveys are interesting. The one by Isukova from Russia, they actually indicate that Lyme is a serious risk factor for miscarriage and perinatal death. I'm not going to continue on with this slide just for time purposes, but these are more serosurveys, and you can see all of these slides. I will have them available. Okay, this is from 2009. Now, this is from Hungary, and what they do is a retrospective review of 95 women with Lyme borreliosis, and wouldn't you know it, a statistically significant association between untreated Lyme and adverse outcomes. One thing in this study that's a bit concerning is that placentas and offspring were not tested for Borrelia by PCR or culture, and so therefore it couldn't be concluded whether or not Lyme the Lyme caused that adverse outcome. Case report number 5. This is from 1968. This is an entire family with Lyme. Starts with mom who was bitten, dad who gets sick about a year later with all kinds of symptoms. A baby is born. This baby is sick. They do Lyme testing on all 3, and guess what? They're all positive. So they start to ask the questions of sexual transmission and transplacental transmission. And you can see there are 9 doctors on this case report, and that's interesting. For 9 doctors to be on a case report means that there are 9 doctors who are very concerned about sexual transmission and transplacental transmission and asking those questions. This case is a little baby who comes into a dermatology clinic at 9 months of age with multiple EM rashes all over his body. And not just EM rashes, but he presents with fever and swollen lymph nodes, and there's no history of a tick bite. Turns out that mom's serology is positive, and this baby started developing these symptoms at 3 weeks of age. Borrelia burgdorferi was isolated by PCR from the skin samples of that baby. And he was put on repeated courses of antibiotics, and he would improve on antibiotics, and then a few months later he would relapse and have to be retreated again, which is suggestive of persistence of Borrelia infection. This is a concerning slide. This is from Schmidt, and they actually find Borrelia burgdorferi DNA in breast milk of 2 women, both who had an EM rash and both who were lactating at the time. There's no reports of Borrelia transmission via breast milk in humans. However, one might consider the precautionary principle. When there isn't proof beyond reasonable doubt, reason and rationale has to come into play. Now we're on to Dr. Tessa Gardner. She authors the most comprehensive, extensive, and thoughtful review of Lyme borreliosis in the fetus and newborn infant. And when we went to Ottawa, I actually presented the Standing Health Committee with this actual textbook because it's so important. So she talks about congenital borreliosis, that because there's not a homogeneous syndrome, that it's hard to prove causation, and yet there are several features that are common amongst the 66 adverse outcomes which she identifies. Here's a little table where she identifies mid-early congenital infection, severe congenital infection, and later onset chronic progressive infection. This is real, you guys. Babies are being born with Lyme disease. She reviews pathologic findings. She finds them in skin biopsies, brain, heart malformations, neuropathology, musculoskeletal abnormalities, renal histopathology. And she says, although there are relatively few cases of congenital Lyme borreliosis reported in the literature, comparisons with congenital syphilis may be appropriate. And she says it is absolutely critical for clinicians caring for newborns and infants to be familiar with adult presentations of Lyme disease, because if you can understand what is happening in adults, then you can understand what is happening in these babies. So you have to be aware and understand what's happening in the adult, so you can also support the congenitally infected infant. Now here's an interesting part. So she says, okay, what about this lack of inflammatory findings? What's up with that? She said, could it be related to the immunopathogenic features of Borrelia burgdorferi infection, and where the spirochete is able to spread and persist in tissues without eliciting a prominent host immune response? Now, this might be way over some of your heads. It was initially way over my head. But what she's saying is there's reason why there's not inflammation in those organs and in those tissues that are found. There's actually rationale for that, and there's reason. She talks about the ability of the spirochete to be invisible to and to be able to evade the host immune system. And she responds to this mechanism as stealth pathogenesis. So, a couple points. Serology is not a sensitive method for diagnosis. There is no tetragenic effect that has been clearly determined, but more research needs to be done. And it is true, there are adverse effects that have been seen in the skin, in the muscles, in the brain, in the bladder. And these symptoms are very similar. It produces similar symptoms in children and adult patients, which would explain why these babies have such a wide variety of adverse events following birth. So, I'm almost done. How do you know if an infant is infected with Lyme? Negative serology does not indicate lack of infection in the infant. Most diagnoses of fetal neonatal deaths were made on histology samples. But here's what you can do. PCR on the cord or infant blood, an Ellie's spot, which is not an antibody response, but rather a cellular response. There's a company called Ceres, which is currently developing a urinary OSP-A test, which could be very helpful to look in the first urine of a newborn baby. Dr. Jones also suggests PCR testing placentas and foreskin remnants. Now, this is quite interesting, of babies, of little boys who are circumcised, to take that foreskin remnant, send it off for PCR testing, and see, is Borrelia burgdorferi in there? And if it is, there you go. We know that that's an answer for you. Another thing very important, prenatal screening tools. I did not know I had Lyme disease 14 years ago when I gave birth to my first daughter. And if there had been a special screening tool that was available for me that could have identified, wow, Sue, you've got all these kind of strange symptoms, that would have helped my physicians to be able to care for me and perhaps even identify a disease and prevent my children from getting infected. So next steps. At LymeHope, we are actively working to bring together an international working group of scientists, healthcare professionals, including doctors, naturopaths, and midwives who are interested in transplacental transmission. I have a group so far of about 7 internationally that have identified themselves as wanting to be a part of this. If you are a healthcare professional in this room and you're part of this one of these categories and you're interested, please contact me because we need more people. We need more support. We need to do retrospective questionnaires and surveys. We need to evaluate short and long-term outcomes of pregnancies complicated by Lyme. We need large-scale prospective longitudinal studies of mother-baby pairs. We need B. burgdorferi-specific evaluations. We need long-term follow-up of each infant born to determine the occurrence of possible early and late sequelae of congenital Lyme borreliosis. Are you interested in participating? You can contact me. I'd love to have more support in this. Thank you so much.